Great. Well, this is our second episode together, and that's just a product of you being super knowledgeable on a lot of different things. So we needed to split this up
I
into
appreciate that. Thank you.
two podcasts. But for those of you who didn't catch the first podcast, Dr. Gonzalez is an expert in both male and female sexual disorders. He's a traditionally trained urologist, but he has specialized in male and female sexual disorders with specialty training, and that's what his practice focuses on. And our last podcast episode, we talked about male sexual dysfunction. And man, I learned a lot that episode. Thank you so much for doing that.
Yeah, it
And
was a pleasure.
yeah, and I know female sexual dysfunction is just as complicated. I know we see, hundreds of women in our clinics that sometimes that's their main concern when they're coming to see us for things such as hormone optimization, and there really is a lot to it. So I'm excited to get your feedback and your approach to this, and kind of what you offer as far as treatment goes.
Yeah, yeah. Let's get into it.
Yeah, for sure. So tell me a little bit, like what kind of patients you see when a woman comes to you. What are her general complaints?
I think that varies based on her age. So I would say I probably see two types, two age groups. So I see sort of the perimenopausal, menopausal aged women, and then I see younger women who have sexual issues, often that are hormonally related, um, uh, that sometimes can be caused by the birth control that they're using.
Oh,
So I see kind of those two big groups. But it's interesting because a lot of times in female sexual health, we split people up between, premenopause and postmenopause.
right.
But a lot of the symptoms, or a lot of the complaints of these two groups of women, are similar. And it's just for two different reasons. One is because of menopause; their body has stopped producing the hormones that they need, and the other one in the younger group often is hormonal problems that arise from, oral contraceptive pills or other hormonal contraceptive options that they may be using.
So that's interesting. So you're seeing that most women, usually the initial cause is something of a hormonal change that then leads to other symptoms as far as sexual dysfunction goes. Is that right?
Yeah, I mean,
You could trace it back to hormones.
it depends on what the problem is, but that is
Uh-huh.
almost uniformly one of the things that we first screen for. So, on our last podcast, we talked about sort of like going through that algorithm to,
Right.
get to come up with, what is the diagnosis? Why are they having this problem? So we do the same thing for women. So, a woman comes in and says, I have no sex drive, for instance, right? That's a pretty broad issue that can be
Right.
influenced by lots of different things. So we, often will do, um, careful history in terms of trying to figure out what is potentially causing this libido issue, right? Is this a woman who has never had a sex drive, or is it somebody who had what they would consider a normal sex drive for some period, and now they have noticed they have noticed a considerable decrease in their interest in sex, right? Um, so the history in those patients is really important. But then, we know that both male and female libido is very hormonally influenced. So we often will do a hormonal screen similar to what we do in men when we see them for problems with erections and that kind of stuff. The interesting part of evaluating women is that one thing, that gets lost in how we think about female sexual health as it relates to hormones is testosterone. So there's, even in women who have been prescribed hormone replacement therapy programs, say for menopausal symptoms, usually that will involve some sort of like estrogen, product and a progesterone product, because, typically we think of those as like female hormones. But the truth is that women produce a lot of testosterone, and their bodies need testosterone for lots of different reasons. And they can continue to have bothersome symptoms related to menopause or even in the younger group because of testosterone deficiency. And so if they're not getting that also, then you're kind of missing a big part of the picture. So that's probably the hormone that I actually use the most in my practice, in terms of treating women for hormonally mediated sexual problems.
Yeah. Yeah, I see that a lot when women, testosterone just gets ignored in hormone replacement therapy programs. What do you
Yeah.
like to see a woman's level around, or do you just go based more by symptoms?
I mean, it's definitely a balance between
Right.
symptoms and levels, right? So there are, if you took every single, woman, let's say premenopause, and did a hormonal screen, you probably would find a number of women with what I would consider less than ideal levels of testosterone, but how they feel related to that isn't always the same. So if you have someone, you just check a blood test and they have less than ideal testosterone, but they have no symptoms, then we don't typically treat those women.
Sure.
But, most of the time, I'm not seeing that patient. I'm seeing the patient because she has symptoms. So we have a pretty narrow window. We kind of go by free testosterone, and that's like a whole the chemical pathway and why free testosterone is a better marker for a better marker to follow than total testosterone is really important. But we monitor free testosterone primarily, and we like that number to be 0.6 to 0.8 nanograms per deciliter, which is a pretty narrow window. But many women fall below that, and we use that number based on the fact that women produce about 1/10 the amount of testosterone, and so it's the equivalent to a man being in the 600 to 800 range.
I see. Got it. So
Yeah.
that's how you're calculating it. So let's talk a little bit about free testosterone versus total testosterone, because I think a lot of our listeners are interested in that, and we talk about that on a lot of podcasts.
Yeah.
And tell me a little bit about what the difference is in your view, and talk about sex. I mean, sex hormone binding globulin, and
Yeah.
why free testosterone is a better one to measure.
Yeah. So I think it's especially important in women. I think total testosterone for men is like a totally, assuming that their SHBG is reasonable. I think
Right.
monitoring total testosterone for men is just an easier thing to measure, and it's totally fine to follow them in that regard. Women, the reason I think free testosterone is a better marker to use is that SHBG in women can be all over the place. And this is basically the primary problem that I see in younger women as it relates to their use of birth control. So when women are on an oral contraceptive pill, or use, the NuvaRing or certain types of hormonal contraceptive options, but mostly the pill, it causes a dramatic increase in their SHBG. So, and the problem is that even after they stop that treatment, let's say they were on the pill for 10 years, they stopped it, and now they've been off of it for a few years, that SHBG level remains elevated. It will usually come down a bit, but it's significantly higher than what you would see if you looked at women who had never been on the pill. So what that means is that even though they, are off the medication, and let's say they're young and they're healthy and they're producing a good amount of total testosterone, like you measure it, it's totally normal, it's actually pretty healthy. If you then, calculate the free testosterone looking at their SHBG and it's really elevated, they can have pretty significant deficiencies in testosterone for many years after birth control use. So the SHBG is sort of the bane of my existence, because it's what is the primary cause of testosterone deficiency that I see in at least my younger female patients. And then, SHBG goes up naturally in both men and women as they age. So, if you're seeing a woman in her mid 30s or early 40s, and she was on birth control for years, she's going to have not only the age-related increase, but also, the increase associated with her prior birth control use.
Sure. I get this question all the time. How can I bring my SHBG down? How can I bring my binding globulin down? What do you tell people to that?
So the only thing that I've seen that has helped that is testosterone. So if you put a woman on systemic testosterone, over time, you will see a decrease in her sex hormone binding globulin. And that is, the mainstay of treatment for our patients, especially the younger ones. The first step is getting them off the pill, because that's the primary issue in a lot of those women. So we stop the pill, usually their SHBG will come down a little bit, but it's not enough for them to now not be deficient. So we add to that a systemic testosterone, and it has two benefits. Number one, it overcomes that SHBG elevation so that they're no longer deficient. And over time, it slowly brings the SHBG down, meaning that, at some point, my goal with all of these women is to take them off the systemic testosterone, so that their body's production is now enough.
Right.
But that takes time. You have to watch that the SHBG kind of come down. So
Right.
other than that, I'm not aware of anything. I wish there was like another, pill or something I could give people to lower
I
that.
know.
That's really the only thing I've seen.
Right. I tell them just kind of live a healthy lifestyle, and hopefully it'll come down a little bit over time.
Yeah.
But other than that, there's not much you can do. And then
Yeah.
I get this question a lot too, as a female, and it applies to men and women. How can you naturally increase your testosterone without having to go through replacement? Because I'm sure you see this a lot, like getting someone on testosterone replacement therapy. People want to try to do it on their own first, right? And so,
Yeah.
what do you tell
Yeah.
people?
I mean, it's not, really much different than what we talked about with regard to men, right? So,
Right.
I think it's sort of a moot point when you're talking about a menopausal woman or a perimenopausal woman, because
Yeah.
the factory is closed. Like their
Right.
ovary is not producing that hormone anymore. So you could, eat super healthy. You could get the best night's sleep. You could be exercising regularly. That factory is just not opening up again.
Right.
So in those women, I'll tell them to do those things, but it's more, this is good for your overall health. But I'm very realistic with them. You are in a stage in your life that you're going to spend the rest of your life in, that that means that you are not going to produce this hormone, no matter what you do. It's just part
Right.
of getting older. Our bodies, in my opinion, we weren't meant to live as long as we're living, right? So like the ovary was primarily, it produces testosterone and progesterone and estradiol, for the purposes of us procreating. And we were all like, biologically meant to die at like 40. So
Yeah.
the fact that we're living, into our 80s and 90s and sometimes even longer means that, we're living a third of our life without proper hormone production. So
Right.
how do we help people continue to do that so they can live healthy and good quality lives,
Right.
So
Absolutely. Yeah. And I talk about that all the time because we were not meant to live to the ages that we live. And,
right.
the reason things shut down at late 30s, mid 40s is because nature is pretty much done with you at that
Right.
point in time.
Right.
But you're not done. You want to stick around for a
Right.
little bit
Right.
longer. And
If you can't reproduce anymore, it's like, you right off into the sunset, basically.
exactly right off of the subset. Yeah. And so hormone replacement hormone replacement, and the story with women has gotten such a bad rap in the
Mhm.
past from just some of the unnatural hormones that were being prescribed to women. And
Absolutely.
what do you tell women as far as hormone replacement therapy and how to get them kind of off that fear that even a lot of primary care doctors are make it
Yeah,
very fearful for patients?
it's very challenging because,
Oh,
you probably know this, but just for the knowledge of your listeners, there was a huge study that came out in the early 2000s called the Women Health Initiative that, was a long study looking at two groups: women on hormone replacement therapy program and women who were receiving placebo. And they found that um, that women on, I'm sorry, not placebo, no treatment, that women in the hormone replacement therapy group were at increased risk for certain adverse effects. So certain types of cancers, blood clots, and premature death. So it scared a lot of people. It got picked up by the media, and doctors, primary care physicians, gynecologists stopped prescribing it. And for years before that study came out, a majority of women in menopause were at least offered, if not prescribed, hormone replacement therapy. So it really was this huge overnight shift. Everyone stopped their treatment. And since that study, it's been almost 20 years. They've reanalyzed that data, and I think it was in 2013 or 2014, and didn't really find a significant difference in adverse outcomes from the two groups with more follow-up. So, number one, I bring that up because a lot of women have heard of it, right? Maybe they don't know specifically about the Women's Health Initiative, but the misinformation that they have related to hormone replacement therapy is influenced by that study, basically.
Right.
So I have to kind of reassure them that, that same study that scared a lot of people was reanalyzed years later, and they actually found no difference in adverse effects. And I also tell them there was a lot of problems with how hormone replacement therapy programs were prescribed during that time, right? Women were put on oral estradiol pills, which we know, after a certain age increase your risk of blood clot. So I don't prescribe oral estradiol therapies. We use other forms, usually like a transdermal, that are not known to increase those risks. So we've adjusted how we deliver the hormone replacement. And the other thing is that there was not really a control in that study for how women, what kind of hormone replacement therapy women got and how they were monitored, right? So as we talked about, I believe last week with men, I monitor these women very closely, like similar to how someone would if they had diabetes or thyroid disease, right? You give someone a thyroid medication, you give someone insulin. You don't say, I'll see you in 6 months to a year.
Right.
You bring them back, you check their levels, you adjust their dosing, and make sure that things stay in a safe and optimal range. And that's what we do with our hormone replacement therapy for both men and women. We have very specific goals and we adjust their dosing as needed. So, I try to provide all that information to kind of debunk things that they may have heard, not only in the media, but also sometimes from their physicians who are just, not well educated about the reality of hormone replacement therapy. So I'm sure you've encountered, the same thing.
Yeah, I'm always, I'm always unwinding the misinformation from media and from also, surprisingly, like you said, even primary care and other physicians, OBGYNs, that still don't believe in the benefits or the power of hormone replacement therapy. And like you said, it's just re-educating people and showing them the research and talking to them about it.
Yeah.
Yeah. All right. Just so we can kind of be complete about hormone replacement therapy too, I'd love for you to talk about some of the other benefits besides, getting your libido back. What are some of the other benefits that women can get from the hormone replacement therapy?
Yeah, it's hugely, hugely important. So yeah, libido is definitely a big thing, but testosterone has a lot of the same effects in women as it does in men. So it's important for sex drive. It's important for maintaining energy. So a lot of women in menopause or even younger women with testosterone deficiency will complain of like chronic fatigue. It helps regulate, mood and anxiety. It helps build lean muscle and decrease body fat. It helps with cognitive function. So, it has a lot of systemic benefits. One of the big things that I see is not actually probably the primary issue related to testosterone deficiency I see in women is not the libido, it's pain. So a lot of women, both young and postmenopausal women, will come to me and complain of pain with sex. And there's different types of pain with sex, but one of the kinds is hormonally mediated because the tissue at the entryway to the vagina, it's an area called the vestibule, is very rich in androgen receptor. So it requires healthy amounts of testosterone to maintain its health. And so we see women with testosterone deficiency who have sort of chronically inflamed and irritated tissue right at the entryway to their vagina. So guess what? Every time they try to have sex, if their partner is penetrating them, that tissue gets rubbed. And it's, what I tell them is it's like you have a scraped knee and you just keep rubbing it. It's never going to heal. And it's at some point you're going to, flinch and not want to engage in that irritative process. So we examine their vestibule, we measure their blood tests, and a lot of times that problem can be completely solved by putting them on testosterone therapy.
So that's awesome information, because that is another big problem that I hear about a lot. Like you said, young women and older women having pain with sex.
Yeah.
And is there any way that a woman can know or test for, or the what you're talking about, the vestibular dryness or the pain, or
Mhm.
how do they understand if they have that or not?
I mean, there's a few sort of symptoms that you could have that would kind of
Mm.
clue you into that. Here's the real problem: is that the vestibule is not something I learned about until I did my fellowship, right? So, like
Right.
in urology, it's primarily focused on men to begin with. But what little interaction we have with females, it tends to be centered around incontinence,
Right.
and we're not really um, educated on the nuances of the female genital tract. So
Hmm.
the first time I even heard the word vestibule was in fellowship, and that's true. Sadly, also for gynecology
Sure.
and other medical fields. So I've seen so many women who have very obvious symptoms of what we call vestibulodynia, pain in their
Hmm.
vestibule, who have seen 10 gynecologists, and they get speculum exams all the time, and their vagina looks fine because the vagina is primarily an estrogen dependent tissue. But when you put that speculum in, if you're not looking at the vestibule before you put it in, you go right past it. So
Mm.
they're kind of missing the problem, or they'll be put on some sort of vaginal estradiol, for this dryness and this pain,
Right.
and it doesn't. Their vaginal lubrication might improve, but the primary source of lubrication during arousal is the vestibule. So if you're not providing the testosterone support, you're still going to have a problem in that area. So the symptoms that are most commonly associated with vestibulodynia, or this vestibule problem, is pain with initial penetration, which we call superficial dyspareunia, um, dryness, um, and then because the vestibule is sort of adjacent to and made of the same tissue as the urethra, we also will see women complain of irritative voiding symptoms. So
Mm.
burning when they urinate or after they urinate, um, frequency and urgency. So a lot of these women get misdiagnosed with recurrent UTIs when no one has found any kind of significant bacterial infection on a urine culture. They'll send cultures, they'll come back negative, but they'll still be given antibiotics. And sometimes it helps and sometimes it doesn't. But and women are also not that aware of their anatomy. Most women that I see don't even know what their vestibule is. So I show
Right.
them in the office with a mirror. This is what I'm talking about. You see how red this is. This is where you had pain when we touched you. This is what's going to get better, over time. So um, yeah, I would say, if you have women who are experiencing pain with initial penetration, they should, at least consider that as one of the causes, and persistent difficulty with lubrication. Those are the
Wow.
two big, or these irritative voiding symptoms. Yeah.
That's huge. I mean, I never heard of it, to be honest with you.
Yeah.
The vestibular dyspareunia. It's an incredible um, amount of knowledge to have. I mean, that's great to know that it's a potential problem because it is treated totally differently. And you see that
Hmm.
knee jerk reaction of gynecologists that when someone has pain with sex, they immediately put them on an estrogen cream, right?
Right.
Because they
Right.
assume that's what's going to take care of it. But what you're saying is it's actually a different problem. It's a testosterone issue,
Correct. Yeah.
right? And so then
Yeah.
when you correct the testosterone, how long does it take for that to kind of normalize again for a woman?
Um, it depends on how bad the starting point is, right? So
Right.
that's where the SHBG value can become really important. If there was one study done by my mentor in the 90s in Boston that took a group of nurses who had never been on birth control, and they measured their SHBG values, and the median value in that study was 25. So that's
Oh,
what I tell all my patients, like the ideal is. No one that I've ever seen has been 25, but that's like in a perfect world, right? Because
right.
most of the women that I've seen have probably been on some sort of oral contraceptive pill at some point in their life. So that's like our goal. We'll never get there, but the closer we can get to that, the better off they'll be. And I've seen women who have had, SHBG levels that are not too bad, like 50 or 60. And I've seen other women who have SHBG levels in the 500s.
Wow.
So, that is a much more challenging issue and will definitely take longer to see improvements because you're battling, you're fighting an uphill battle against that protein,
Yeah.
and so we sometimes will have to use higher, than usual doses of testosterone in those women to overcome that problem. But women, even in those kind of bad scenarios, will start reporting even some of the systemic benefits of testosterone therapy within weeks of starting the treatment. So it may not take away their pain completely, but they'll often start reporting, oh, I feel like I am lubricating a little bit better, or I definitely see an improvement in my energy, or I find myself thinking about sex more. I may not be ready to have sex because it's still, irritated and painful, but I'm at least thinking about it, which I didn't do before, So the benefits, typically we see them within weeks of starting them on treatment.
Yeah. And so like I imagine there's a lot of like psychological pain that occurs as well with this, where someone is having pain, but then they, of course, that's going to cause a certain level of not having interest in sex, and that just
Yeah,
kind of becomes a
absolutely.
vicious cycle, right? And so
Absolutely. Yeah.
yeah, and so I'm sure you're also talking about that, and there's, I'm sure there's some shame involved, there's some guilt involved, etc.,
Yeah.
that you have to overcome as well.
There's a few sort of consistent factors that we see. So number one, we kind of talked about the hormonal issue, which is something
Right.
that I can fix, right? Secondary thing that can happen is that, and it makes sense if you think about it, if you have a tissue down there that is chronically irritated and it's constantly being rubbed, because most women, if they're in a relationship or they care about their partner, they want to have sex, and you'll find that women will like suffer through sex just so that they can have that intimacy, or they can please their partner and they want to feel attached to their partner. So a lot of these women will still have sex, even if it's uncomfortable or painful. But it's trauma every time they do. And
Right.
so not only is it creating sort of psychological trauma, but it also creates a almost a reflexive tightening of the muscles in their pelvis, right? So the other big thing that I do when I see a woman who has this hormonal issue is have her see a pelvic floor physical therapist, because almost undoubtedly there's going to be some myofascial or sort of muscular component to their issue, because their brain says to tighten
Right.
everything, prepare yourself for this traumatic, painful experience, and so they tighten. And so even if I'm fixing the hormone issue, if you're not addressing that unconscious, tightness in their muscles, then you're still going to have a problem, even when the hormone issue corrects. So, I work very closely with pelvic floor physical therapists. I work closely with psychotherapists and sex therapists to help address the psychological aspect of this, because it's a very complicated issue. It's not just
Yeah.
if I put them on hormones, everything's going to get better.
Yeah, so it's a multimodal kind of process to get through this, but the initial inciting cause is the testosterone deficiency.
A lot of times, sometimes I see women who present with all of them at the same time. They
Right.
come to me with all three, and so I'm just like, I don't know. It's sort of chicken or the egg. I don't know what came first,
Right.
but I definitely tell them we have to address all three of these issues:
Right.
the brain, the muscles, and the tissue. The hormone problem. And then the other thing that happens is, I'm sure a little bit about like pain perception in the brain, right? So if you constantly engage in something that is painful, you can actually overly sensitize the brain. And
Right.
then even if you remove that stimulus or fix the pain problem, the brain is still hypersensitive. And so sometimes we have to use medications that act centrally to numb that signal, while they're
Mm.
going through the physical therapy, while they're going through the hormonal treatment, because they're so, they're at an 11 all the time. Their brain is
Right.
like constantly prepared for pain, and you have to
Hmm.
kind of dull that down.
And what medications do you use for that?
It depends. I like the SNRIs. So
Hmm.
like Cymbalta is one that I commonly use. Um, a lot of those medicines can be tricky because they can have side effects. They can be sedating. They can cause weight gain.
Right.
They're not always easy to get people off. Sometimes you have to wean them off. carefully. So I do my best to not use those medications, but in that really, really hypersensitive patient, sometimes you have to.
Right.
So yeah, I primarily use the SNRIs.
Got it. Got it. Wow. Yeah, that's so important. I think, for the women and men who are listening to this podcast, this is actually a huge problem. It's
Yeah.
just, I would say, it's just as big of a problem as erectile dysfunction in men, that it's just not talked about.
Oh, absolutely.
And right, I bet it takes a while for someone to come to see you about something like this.
Yeah, and I think going back to this whole psychological trauma, right? There's a psychological trauma of having pain, having sex constantly be associated with pain, and what
Right.
that does to your self-esteem, and what that does to your relationship, and your ability to be intimate with a partner. But then there's also the psychological trauma that is uh, induced by medical providers. You know what I mean? I've seen
Sure.
so many women who have finally gotten the courage together to talk to their gynecologist about this, or their primary care doctor about this, and the answers that they get sometimes are just shocking and honestly appalling. I mean, if sometimes I've had women say, "Oh, I talked to my gynecologist about this years ago, and she said, well, you should just have a couple glasses of wine and relax." And it's
Oh,
like, that is so counterproductive and actually harmful to someone's psyche. They already have shame about it, right? I mean, they're already, it's probably
right.
already affecting how they feel about themselves and their relationship and all of this stuff. And then you add to that, they're going to see a quote unquote expert or a medical provider who then tells them it's basically in your head, just relax, or they'll get told, well, it's just because you're unhappy in your relationship, you just need to find a
Mhm.
new partner. And it's, the truth is, like, they may love their partner dearly and want to be they're talking about it because they want to be intimate with that person. So yeah, I mean, I think that that when I see patients, a lot of patients have seen other people about it,
Yeah.
and they've just not been given good information, or sometimes even been harmed even more, which is
Right.
unfortunate.
I hope there's a lot of medical providers also listening to this episode, because I think it's a great education for them on how to treat something that is
Yeah.
a huge problem, and not ignored. What other things can you do besides the testosterone replacement and the pelvic
Hmm.
floor therapy and maybe some SNRIs? What other things you put into your kind of your armamentarium with this type of problem?
For the pain issue,
Yeah.
so we use, I mean, the hormone stuff is probably the mainstay.
Right.
But sometimes people, like, we put them in physical therapy and they're making some progress, but maybe they've had this problem for 10 years and they are just tight. No matter what
Right.
the physical therapist does, they'll have a day or two where their muscles can relax, and then they just go right back to that tightness. So then we add the SNRI. But sometimes we have to use things more aggressively, whether that, sometimes we use muscle relaxants.
Right.
We'll prescribe, traditional skeletal muscle relaxants, cyclobenzaprine, those sorts of things.
Uh-huh.
Sometimes we'll use Valium in the form of a suppository that they can place, rectally or vaginally, to help relax the muscles in their pelvic floor. Some patients need pelvic floor Botox,
Uh-huh.
or if the nerves running in that area are affected and they're having neuropathies, sometimes we'll do pudendal nerve blocks, or sympathetic ganglion blocks. Now, those sorts of things I'm not personally doing. I have some pain specialists that I work with that are doing
Right.
those kinds of injections. But yeah, I mean, we have to think um, kind of broadly about these things. And I
Right.
one, one of my close friends and colleagues who's a physical therapist in LA, we joke all the time that with these sorts of issues, it really takes a village. And so we've kind of spent the last few years kind of putting together our pelvic pain village, to a
Uh-huh.
certain degree, where I'm doing the hormonal management and then they're doing the muscle component. And then sometimes we're having them see a pain psychologist or a sex therapist, and they're going to see the pain doctor if they need these muscle, Botox injections or whatever. And it really, sometimes it takes, 5, 6 people to like help
Right.
one person, to
Yeah.
address all of the components of their problem.
That's why I asked the question, is just that, just to give women hope that there is something you could do about this. And it's not just hormone replacement, which, is a great first step and probably would take care of most people, but you can go down the line and there's other therapies involved. So, I think a lot of people just think there's no treatment for something like this. And the
Yeah.
laundry list of treatments you gave, I mean, that's so hopeful for people.
Yeah. Yeah, absolutely. I mean, there's definitely, um, not too different from what we talked about regarding men last week is, there's a solution for everything. It's just about figuring out what the issues are and coming up with a plan to address each of those components,
Right.
and we outline that plan for patients. Um, and it can be really, it provides them hope. Like I just talked to a woman this week, a younger woman who, she emailed me and she said, I'm kind of spinning out. I like made the mistake of Googling my symptoms, and she's like, I need some reassurance. So I talked to her on the phone and I said, this is how I'm thinking about it. We're treating you with the hormones. If you don't get better with the hormones, these are the other things that we're going to pursue. And just with that 5-minute discussion of how I'm thinking about it and what the plan is, she was like, I feel so much better. So, that's really important also for, like you were saying, for women to understand that there are solutions out there. And then, of course, I encourage her to stay off the internet because it can be a dark place, and a lot, dispel a lot of
Yeah.
misinformation. So.
Yeah, and I find that the internet is really good at skimming the surface and just
Yeah.
giving you like one-liners for what this is and what the treatment is, and then it just stops there, and it's just so much more in depth, like you explained. So definitely, they need to see a specialist like yourself to get through all that. So let's kind of shift gears a little bit. We talked a lot about the low testosterone as being a major problem, probably the number one problem I would say that I see. What other things do women come to you for?
So I would say that the most common things that I get seen for are the pain, the pain with sex, and then we can go back and talk about low libido, and other things that can influence low libido. That's another big category of women I see, and then sometimes traditional sort of urological issues like recurrent UTIs or frequency urgency, and we still, if they have a history that is suspicious for having a hormone issue, sometimes we'll still evaluate them hormonally, and their urinary issues suddenly get better with these hormone treatments. But yeah, those are the three: the pain, libido, urological issues, and probably menopausal management. Those are primary issues that I see. Yeah.
So you mentioned there's some other causes of low libido. What are those?
So it has to do with brain chemistry, essentially, right? So I mean, I guess let's take a step back. So there's the hormone issue. Let's say either a woman's hormones are perfect, or she has a hormone issue and we correct it. Women can still have a libido issue, even that's not hormonally related. It can, it has to do with external factors. Like everyone's libido right now is low because we're all super stressed out. We're all, cooped up in our homes and worried about our jobs and worried about, the future and all of that sort of stuff. So, external stressors, relationship factors, mood, history of depression can certainly affect libido. But those aren't things that I can necessarily help out with, right? So, but one of the things that we also know is that certain neurotransmitters are excitatory and certain are inhibitory, and certain neurotransmitters are really favorable from a libido standpoint and others are not. So serotonin, as an example, is a inhibitory a neurotransmitter and tends to have a negative effect on libido, which is why women on SSRIs like Paxil and those sorts of things, one of the main side effects is low libido. They'll report that. And it's because you get an increase in your serotonin levels. So another neurotransmitter that's really important is dopamine. And that tends to have the opposite effect. It is excitatory and it has a positive effect on libido. And so we use that knowledge to pick medications to try to shift the balance. And there's not really a way that I'm measuring that. I'm not doing like spinal taps on people and measuring dopamine and serotonin levels, but it's something that we can experiment with and try. And it's a relatively safe thing to do as long as patients are willing to try it. But basically, we'll put them on medications that increase dopamine or lower serotonin. There are other pro-libidinous, pro-sexual function excitatory neurotransmitters like norepinephrine. So other medicines that increase norepinephrine can also be used. But it's a little bit of, this is not, for the most part, libido is not a well-studied, thing in medicine. Up until a few years ago, there were no FDA-approved drugs specifically for libido issues. Now there are two that have to do with non-hormonal issues as they relate to libido. So a lot of it's experiment, and sometimes one medication will work really well for one person and we'll try it for the next person. It has no effect. And so we have to kind of experiment a little bit with these kinds of treatments.
That's great to know. So like the two drugs you said that are approved, are those like the female Viagra drugs?
Yeah,
you're referring to, or?
Yeah, it's a little problematic to think of them like Viagra.
Yeah.
But Viagra, for those that don't know, is a vasodilating medication, right? It dilates your blood vessels. That's why you get a hard-on and increased arousal in your genitals. The medicines that are available, the first one that was FDA approved came out a few years ago. It's called flibanserin. And it's a pink pill, so people started calling it female Viagra, but it's taken completely differently. It's taken every night. It's not taken on demand for sex like Viagra and the PDE5 inhibitors. And it works differently. It's not a vasodilator. It has this effect centrally on your brain and the neurochemistry of your brain. And it tends to have a favorable effect on dopamine, serotonin, and norepinephrine levels, such that you get more of the excitatory and a decrease in the serotonin.
Got it.
So that one's taken nightly. And then more recently, last year, an injection came out that is delivered through like a pen auto injector. And that one is more closely related to Viagra in terms of how it's dosed. So that one is used on demand, usually 45 minutes before sexual activity. And you administer it typically into the subcutaneous fat of the abdomen or like the leg. And that is I think we talked a little bit about this last time, because you were asking about peptides. So it's called bremelanotide. And that one also has sort of central effects that increase excitation and therefore have a positive increase on libido.
Right. Fantastic. That's also very good for people to know as an adjunctive treatment. Do you sometimes use that in addition to testosterone or for a little while?
Yeah, absolutely. So I'm not like a throw the kitchen sink at a patient kind of person, but I do want to try to do as much as I can as quickly as possible to get them functional again. Because again, a lot of times when they've seen me, it's been years, months or years that they've been in the state. So if they're open to it, or certainly let's say a woman comes to me with low libido, we find her testosterone is low. I'm going to put her on testosterone, but let's say she has a history of depression and she's on an SSRI. We can try to get her off of that, or sometimes we actually add one of those dopamine medications to try to counteract the negative sexual side effects of that. And so that becomes a little tricky too, because you don't want to obviously screw with someone's mental health. If they've been stable on this antidepressant for a while, you don't want their depression to come back in exchange for like an increase in their libido. So a lot of times I'll have to work with their psychiatrist or their primary provider that may be prescribing these medications, see if they're open to either switching them to a more sex-friendly antidepressant or at least adding something to try to counteract it. So yeah, it's a little bit of, I'm I I do whatever I can as quickly as possible. I'm not going to put them on like 5 different central acting medications, but
Right.
very quickly we will try to have a positive influence on the brain as it relates to
Yeah.
libido.
Yeah. It's like, it's kind of like, you have to be a specialist, not just in urology, but also psychology and also hormones,
Yeah,
endocrinology. It's very multifactorial. Like you said, it takes a village. And,
yeah.
yeah, you have to have knowledge about all of this. So let me ask you, well, what do you feel about these injectables into the kind of the vaginal canal, so-called O shots? What do you think about
hmm
those?
So for those that don't know, the OSHOT is like a proprietary form of PRP that's basically injected into the female genital tissue, usually periurethral, sometimes in the clitoris or the labia. Um, there's not good data showing that it really makes any difference. It goes back to, I think, safety and efficacy, right?
Right.
These treatments are generally pretty safe. They're injecting your own platelet rich plasma back into you, so the likelihood that you're going to have some sort of reaction, very, very low. The likelihood that you would cause some sort of problem from this treatment, very, very low. I don't particularly do these shots. I've offered it to women with orgasmic issues, where they're not really responding to any other treatments. Um, but I haven't had anybody um, go through with it.
Right.
So I don't have any personal experience with it, but I just know that the data that support that this kind of stuff works is pretty limited. And then we also don't know how long it's going to work, right? So let's say you do have someone report improvements in orgasmic function after getting a PRP shot. How long does that last? Are they going to have to come in every 3 months to get this PRP shot? So I think that is where the challenge with that kind of treatment is.
Right. And so you mentioned there are other treatments available for women that are having trouble reaching orgasm. What are some of the other treatments?
Um, Honestly, orgasmic dysfunction is one of the most challenging things to treat, especially when
I
you're
bet.
talking about primary anorgasmia, which is basically, a woman who has never been able to orgasm.
Mm.
Um, you have to make sure. I send those patients to like sex therapists, to physical therapists, because maybe it's something behavioral that they're doing. Maybe it's that they're not, don't have good control of their pelvic floor muscles, which are really important for increasing tension and releasing that tension, which is part of the orgasmic experience. We put them on hormonal treatments because orgasm is very hormonally sensitive. We use the central acting agents, again, using that sort of dichotomy between excitatory and inhibitory. So with those sorts of patients, I tell them from the very beginning, there are no FDA approved treatments. There are no definite, this is going to work for you kind of treatments. So this is all experimentation. We will do it very safely. If you're open to doing it, we'll just try everything. And some patients, will get closer to being able to orgasm, but it's very, very challenging to take someone who has never orgasmed and get them to be able to orgasm. If it is biologically mediated, if it's something trauma related or muscle control or something like that, that is treatable. But
Mm.
it can be very challenging.
No.
One of the other modalities that we use is the CO2 fractional laser for sort of restoring vaginal, vestibular, and vulvar health. And one of the areas that we treat is also the clitoris typically. And so that can help with things that are important for orgasm. So that can help with dryness, that can help reduce pain, that can help make tissues more sensitive. So that's something that we are able to offer patients. That's has clinical trials showing that it helps with at least pain and lubrication. And we know those are both really important for having good orgasmic function. So that's
Wow.
another thing that we kind of keep in our armamentarium for helping with orgasm issues.
Wow, that's amazing. So you actually do like a CO2 laser resurfacing of the tissues? Is that kind of like someone would have
Yeah,
like
so
a funeral done?
yeah, so there's a few different lasers on the market.
Hmm.
The one that we use in my practice is called the Mona Lisa laser, Mona Lisa touch, excuse me. And basically, it's an intravaginal probe that you insert, and it's got the ability to fire the laser all the way around. And you basically, as you withdraw the device, you are turning it so that it's treating the entire vaginal mucosa. And then they actually have a flat probe as well, which is really nice because it's difficult to treat the vestibule with just the intravaginal probe. So you switch to the flat probe, and you can visualize the vestibule and specifically treat the vestibule, and externally you can treat the labia and clitoris. So I have never treated anyone who hasn't had a positive response to the laser. But it really depends on, this kind of goes back to like our shockwave discussion from last week about male sexual function. For me, it's really about patient selection. I don't market the laser in my practice for vaginal rejuvenation. In fact, there was an FDA warning against doing that because there were some adverse effects that were reported, and I think there's some lawsuits around these lasers because of adverse effects. I'm not trying to make a woman in her 50s like she's 25 again. I'm trying to restore function. And so those are the patients that I'm offering it to. I'm offering it to, menopausal women who are doing the hormone replacement therapy program, and they just got like 10%, 20% more to get completely better. You know what I mean? It acts as a very good adjunct to those treatments, to the hormonal treatments. And I also think it's a good option for patients who, for whatever reason, can't be on hormone replacement therapy. Like, for instance, you have a breast cancer patient who had an estrogen receptor positive breast cancer, you can't put that woman on estrogen. So she could continue to have issues related to dryness and pain because you can't give her that hormone. So that's where I think it can become very, very useful.
Wow, another thing that people can do. That's awesome.
Yeah.
And then I know you talked a lot about female sexual health right now. I have one last question for you, just to be complete. What about, is there a role for labioplasty? Do you do that in treating sexual dysfunction?
I don't do labioplasties because in general, those surgeries are not about dysfunction. They're about cosmesis, cosmetics. So I can't think of a case where a woman would require a labiaplasty because it's somehow interfering with her sexual function. And because that's how I approach this, I don't do those procedures. Physicians who do perform those procedures, I hope that they have a good knowledge of genital anatomy. I don't think that someone who's like spending their whole, all of their time doing facelifts and, breast augmentations should, necessarily be doing that. I would hope that it would be someone with some kind of experience with the genital tissues. I say that because I've heard of women who've had, long-term adverse effects from those kinds of cosmetic surgeries that can interfere with their ability to orgasm, or maybe now they've developed scar tissue and it's causing pain and those sorts of things. So, there's a couple people out there that have sort of double training in like urology or gynecology and plastics. And I think, if someone is going to have that kind of surgery done, you're going to want to go to someone with that kind of knowledge, but I personally don't do them.
Yeah, it makes a lot of sense. One of the reasons I ask that question, I think a lot of times, that particular procedure is marketed as something that could help with sex, and really, like you said, it's more for cosmetics. I don't see how it could potentially do that, but just like you said, women need to be wary. They need to be careful, do their research, and also realize the procedure could cause sexual issues
Exactly.
inadvertently.
And I think one of the downsides to a surgery like labiaplasty is that it inherently tells women that there's something wrong with how their genitals look. And we know, that women's and men's genitalia can look, vastly different, but it doesn't mean that one, appearance is better than the other. If you happen to have labia that are bigger than someone else, that doesn't mean that you're going to have a sexual problem. And I think it becomes a little bit harmful to suggest to women that their genitals have to look a certain way, and that there's some sort of ideal of how things should look. And that's influenced from our exposure to porn, I think, a lot. How we think about how things are supposed to look. But I think it's dangerous to make women feel like their genitals have to look a certain way.
Yeah, absolutely. It's so true. And like you said, just because your labia is larger doesn't mean that's necessarily the reason you're having this sexual dysfunction. In fact, it's probably not. So someone needs to be evaluated on a hormonal level. Their vestibular needs to be evaluated, like you were saying, before they undergo a procedure like that, because it can make things worse.
Yeah, absolutely.
Yeah. Wow. Well, this was a wealth of information, and we've been talking for over an hour, I think, Dr. Gonzalez. Thank you so much. Is there any other last words you want to put out there for the women that are listening to this?
I always say, if you are having pain with sex, that is not normal, because I think as a society, depending on the age of the woman, we have normalized that, so that women are not comfortable talking about it to their peers, to healthcare providers. So if you're having sex and it's painful, that's not normal. So you should talk to someone about that. The second step to that is, if you talk to someone who's a medical professional and you are not being offered real diagnosis and solution to that diagnosis, then you have to move on and find someone else who can provide that. And unfortunately, in this space, it requires sometimes patients to advocate on their own behalf, and to educate themselves on their own, because there's a lack of knowledge in our profession. Unfortunately, it's just not something that is taught to us during our training. So you should find someone who can provide you the diagnosis for your problem and a solution for that diagnosis. And there's a couple of resources. I mean, there's whole societies that study this. I'm involved with an organization called ISSWSH, which is the International Society for the Study of Women's Sexual Health. Their website, isswish.org, isswsh.org, has a provider finder. So you can look for providers that belong to this organization, are well informed about these issues in your neighborhood. And depending on where you live, that's not always, may not be down the street, but at least you can reach out to those providers and see if they have a contact maybe closer to you. So I encourage women to not give up. There are solutions. You just have to find someone who knows about these issues.
Right. That's awesome. Awesome advice. And where can people find you, Dr. Gonzalez?
You can go to my website, which is just joshuagonzalezmd.com. I'm on social media, Facebook and Instagram at Joshua Gonzalez MD, on Twitter at SexMedLA. My office is in the LA area. You can call our office to schedule an appointment. You can make an appointment through the website. So there's plenty of ways to reach me and learn more information. I have a ton of information on my website. So.
Fantastic. This was great. Thank you so much for your time.
Yeah, thank you.
Have a great rest of your weekend.
All right, you too. Take care.
All right. Take care. Thank you.